Hi, I'm Angela Shepard, and we will be presenting tension pneumothorax and hemothorax today. Some objectives that we'll be covering today will be describing clinical manifestations of tension pneumothorax, 2 risk factors for tension pneumothorax, how hemothorax is diagnosed, the treatment methods for tension pneumothorax and the hemothorax, the most common cause of hemothorax, example on how the patient may be impacted by tension pneumothorax, and 2 potential problems to be addressed in the plan of care. Tension pneumothorax is a buildup of air within the pleural space, allowing air to escape but not to return. Tissue forms a one-way valve, allowing air to flow in with inhalation, but prohibits the outflow of air. It's a life-threatening condition requiring immediate attention. This can lead to hemodynamic compromise in respiratory and/or blood circulation. Pressure in the pleural space causes the lung to collapse, the heart to compress, and the mediastinum to shift. It is Greek-derived from the word pneumo, meaning air, and from thorax, meaning chest. The oldest known thoracic drainage dates back to BC with Hippocrates. He used a scalpel to make the incision, leaving the tube in for 2 weeks to drain. And this is just an example, a picture of tension pneumothorax. You can see the air in the space with a compressed heart, lungs, and the shift in the mediastinum. Tension pneumothorax leads to a complication of estimated 1 to 2% of spontaneous pneumothoraxis. 1 to 3% of ICU patients have tension pneumothoraxis. Death of mechanically ventilated patients is 38 times higher when patients have a tension pneumothorax. Unable to determine the incidence of tension pneumothorax outside of hospitals, with reported cases being 0.7 to 30% of general trauma patients. Tension pneumothoraxes are present in approximately 5% of combat casualties with thoracic trauma. Hemothorax is accumulation of blood in the pleural cavity, usually due to blunt or penetrating chest trauma. Dates back to ancient times. Major injuries were difficult to treat and often lethal. Intercostal incision and drainage were introduced in 1794 by a surgeon named John Hunter. Trocar and cannula, followed by underwater drainage, seal drainage, in the 1870s became standard practice. This technique has remained the most common form of treatment for hemothorax and other fluid collections to this day. And this is just an example of a hemothorax where blood is filling the pleural space. There are an estimated of 300,000 cases of hemothorax each year. Most frequently caused by chest trauma, and this can be blunt or penetrating chest trauma. And 40% of patients with blunt chest trauma develop hemothoraxis. The next part of this presentation will be done by Belinda Casey by video.
Hello, thank y'all for coming today. My name is Belinda, and I will be going over risk factors, pathophysiology, and signs and symptoms of a pneumothorax. Risk factors include your sex. Men, greater than women, tend to have a higher incidence of getting a pneumothorax, especially if they're very tall and very thin. If you smoke, the risk of getting a pneumothorax increases with the length of time that you smoke, as well as the number of cigarettes you smoke each day. Your age also can determine if you're getting pneumothorax. Between the ages of 20 and 40 years old is when we see the most incidences of pneumothoraxis. Genetics also plays a part in it. There are certain types of pneumothoraxes that appear to run in families. That means, more than one family member gets a pneumothorax. If you have COPD, then you're also at increased risk of getting a pneumothorax. People that are on mechanical ventilation, and also if you've had a pneumothorax in the past, you're more at risk to develop another one. The pathophysiology for the pneumothorax, it is air in the pleural space causing partial or complete lung collapse. Pneumothoraxes can occur spontaneously or as a result of trauma or medical procedures. Diagnosis is based upon the clinical criteria and a chest X-ray. The signs and symptoms of pneumothorax is sudden chest pain, pain that is sharp and tight in your chest, shortness of breath, increased heart rate, increased breathing rate, tiredness or fatigue, cough, and cyanotic, which is the blue tint to your skin and lips, meaning that you're not getting enough oxygenation. Thank you. Now I'm going to turn it over to our next presenter.
Hi, I'm Dwight Moore. Today I'll be presenting to you pneumothorax. Right here, what we have is an image of your lungs. We got the trachea. It's just giving you the showing you about the small pneumothorax here, where the lung is collapsing on this side. Also, we got the large pneumothorax right here that has a lot of air. And as you can see the trachea kind of deviating here. Also, you have another image that shows the treatment of a large pneumothorax, which is chest tube. And what the chest tube does is just releases the air. Diagnosis. The diagnosis comes from the history and the physical examination, which remains the key to making the diagnosis of pneumothorax. Examination of patients with this condition may reveal diaphoresis and cyanosis in the cases of tension pneumothorax. Affected patients may also reveal altered mental status changes, including decreased alertness and/or consciousness. Findings on the lung auscultations vary depending on the extent of the pneumothorax. Respiratory findings may include the following: respiratory distress, considered a universal finding in pneumothorax, or respiratory arrest. Tachypnea or bradypnea as a pre-terminal event. Asymmetric lung expansion, mediastinal and tracheal shift to contralateral side, which is in the large pneumothorax, is what I showed on the image prior to this. Distant or absent breath sounds, unilaterally decreased absent lung sounds that are common, but decreased air entry may be absent even in the advanced state of pneumothorax. Minimum lung sounds transmitted from unaffected hemothorax with auscultation at mid-axillary line. Hyperrenicence on percussion, rare findings may be absent even in an advanced state. Decreased tactile phrenitis, adventitious lung sounds, crackles, and wheezes. A pneumothorax is generally diagnosed using a chest X-ray. In some cases, a CT scan may be needed to provide more detailed images. CT scanners combine with X-ray images taken from many different directions to produce cross-sectional views of internal structures. If only a small portion of your lung is collapsed, your doctor may simply monitor your condition with a series of chest X-rays until the excess air is completely absorbed. and your lung has re-expanded. Normally this takes a week or two, and supplemental oxygen may speed the absorption process. If a larger area of your lung has collapsed, it's likely that a needle or chest tube will be used to remove the excess air. On the needle decompression, a large bore 14 gauge or larger catheter over needle device is inserted into the second intercostal space in the midclavicular line of the affected side over the top of the rib and perpendicular to the chest wall. A rush of air should be heard, which will confirm the diagnosis. This will relieve the pressure on the mediastinum and create an open pneumothorax, which is less likely to be lethal. The needle is removed and the catheter is left in while setting up for chest tube placement. A chest tube insertion will follow and will be inserted in either the second intercostal space or the fifth intercostal space. The chest tube will then be connected to an underwater drainage system, and a chest x-ray will be necessary to confirm the placement of the chest tube and re-expansion of the lungs. If a chest tube doesn't solve your problem, surgery may be necessary to close the air leak. In most cases, the surgery can be performed through small incisions using a tiny fiber optic camera and narrow long-handled surgical tube. The surgeon will look for the leaking blood and close it off. This is just an image of a tension pneumothorax. You can kind of see where the trachea is starting to shift, the mediastinum, all that is starting to shift. This here is just another image to kind of give you a better view. This is where the trauma was, and so what it is shifting over to the left side, where it's compressing the heart and the other lung. Here is another view of pretty much the same thing, where it shows you where the trachea has deviated, where all your organs, your heart and your lungs, all that is compressed. And in a needle decompression, you will put it right here. You'll put the needle in where the air will just come out. You'll hear a gushing sound. The prognosis. The prognosis of a patient with tension pneumothorax is good if detected early and the underlying cause is treated. Emergency personnel are trained to recognize and treat tension pneumothorax in the field so that valuable time is not lost. Nurses in the hospital setting, especially in critical care units, should also be able to recognize and intervene in order to prevent a fatal outcome. The outcome of pneumothorax depends upon the extent and type of pneumothorax. A small spontaneous pneumothorax will generally resolve on its own without treatment. And a secondary pneumothorax associated with the underlying disease, even when small, is much more serious and carries a significant mortality rate. A second pneumothorax requires urgent and immediate treatment. Having one pneumothorax increases the risk of developing the condition again. The reoccurrence rate for both primary and secondary pneumothorax is about 40%. Most reoccurrences occur within 6 months to 3 years. Reoccurrences are more common among patients who smoke, patients with COPD, and patients with AIDS. Predictors of recurrence include pulmonary fibrosis, younger age, and increased height to weight ratio. In a retrospective study of 102 consecutive patients with a newly diagnosed first episode of pneumothorax, a higher rate of recurrence was noted in taller patients, thin patients, and patients with SSP. Once the cause of collapsed lung is treated, it usually will return to normal within 48 to 72 hours. Recovering from a collapsed lung may take up to several weeks. Once a collapsed lung has re-expanded and healed, there is usually no long-term effect on your health. However, up to 50% of people have a lung collapse again, especially within a few months of the first one. To decrease the risk of a second collapsed lung again, you need to stop smoking, avoid changes in air pressure, such as from flying in unpressurized aircraft or scuba diving. Ethical issues pertinent to the injury disease process. A radiographer must explain the procedures to test for pneumothorax to the patient. This helps the patient not only understand but relax. Testing for pneumothorax requires a technique where they must take a deep breath and then stop breathing without breathing for at least a second. The radiographer should explain that the aforementioned technique has to be done so that the lungs and chest cavity fully expands after a deep breath. This allows the images from the ultrasonography, the CT scan, or whatever method is used to show the pathologies as lung marking diminishes in pneumothorax conditions. The radiographer is also responsible for using the ALARA as low as responsible achievable rule when it comes to treating pneumothorax. Treatment for pneumothorax requires radiation treatment. The radiographer is required to consider the ALARA rule before exposing the patient to the radiation. The exposure should be as low as possible, for high levels of radiation may result in burns and damages on the internal organ.
I'm John Lewis. I've got the next part. We're going to talk about the impact on the patient and the family and society. A pneumothorax can be a really big deal for the person involved. You can't breathe, it hurts, it's very traumatic both physically and psychologically. It can also affect the family. If you're watching somebody in your family go through this, it's going to be pretty traumatic for you too. Now, all that being said, pneumothorax, hemothorax can be very expensive. It means you're going to the hospital, you're going to have an ER bill, and everything that goes with that. Average hospital stay is 2.8 days. You're probably going to go to the ICU. Again, very expensive. It's all pretty subjective though, depending on the severity and consults, complications, whatever treatments they have to do. No matter what, it's going to be expensive, and that also depends on your insurance. Here's some resources. You can look these up on Google. It's a simple Google search. They have all kinds of support groups for people that have been through this sort of thing. Plan of care. Most of these are nursing diagnoses. Here's just a quick problem list. Pneumothorax can cause impaired gas exchange, inadequate tissue perfusion, acute pain, obviously. Patients likely have a knowledge deficit on the subject, and there is definitely a risk for infection. Some more problems, risk for suffocation, risk for atelectasis, skin breakdown, thrombus, which pretty much goes with any hospital stay, and ineffective coping risk. So for this plan of care, kind of imagined an ER visit with somebody that has a pneumo bad enough to need a chest tube. So that patient's going to have impaired gas exchange, inadequate ventilation results in insufficient exchange of O2 and CO2. In that situation, the doctor's going to insert a chest tube. The nurse is going to help with that. They're going to set up and basically get whatever the doc needs. The RN is going to monitor the patient before, during, and after the procedure also. So we're responsible for that too. Respiratory is going to be a big component in this scenario. Respiratory can assist with the procedure and be there if something goes bad. They provide supplemental oxygen with the nurse, and they check ABGs before and after to see where we're at. Then we've got inadequate tissue perfusion. So obviously if you're not exchanging gases like you should, then you're going to have a systemic effect. The tissues aren't going to be perfused, so you can monitor that. So the doctor's going to insert the chest tube and order all the labs, including ABGs. The nurse is going to assist with the chest tube again and monitor the patient for systemic effects, cyanosis, decreased level of consciousness, work rate, depth, symmetry of breathing, O2 sat, peripheral pulses, and capillary fill, and heart rate too. So you're basically going to keep a really close eye on these patients. Respiratory and RN provide supplemental O2, and they titrate it before, during, and after. Probably before you're going to have this patient on a non-rebreather, but after you can start to wean them off the oxygen. And again, a respiratory is going to get the blood gases. This patient's going to be in a lot of pain, likely, and they will probably be freaking out a little bit too. So pain medicine is going to be key in this situation for a lot of reasons. It's going to calm them down. When patients are calmer, they can breathe a little bit better. But it's also going to make it a little less traumatic from a pain standpoint. So the RN initially assesses the pain, lets the doctor know where we're at, what we need, and the doctor's going to order the meds. Pharmacy supplies those meds, and the nurse will reevaluate the pain level afterwards. Risk for infection. After a pneumo, you're at an increased risk for pneumonia. Your lungs aren't obviously going to be working as well, so you're going to have more of a chance for bacteria to set in that lung. Also, you've got a new hole there, which is a new pathway for infection. So you've got to keep a close eye on the site for infection and, chest x-rays and labs too. So during the procedure, the doctor and the nurse need to maintain sterility during the chest tube placement. That's very important. The doctor's going to order antibiotics either way. The nurse is going to give antibiotics. Pharmacy supplies those antibiotics, and the nurse keeps an eye on the patient for infection. Lab, of course, is going to draw blood as scheduled to keep an eye on white count and everything else. This patient and the family are probably going to have a knowledge deficit related to pneumothorax, hemothorax, whatever they're going through. This isn't something that people just know about. So it's our job to teach them the whole time. When they come in, before they come in, the whole time, EMS, the nurse, the doctor, respiratory lab, everybody should be keeping these people informed on what's going on and what's going to happen. And the status. The nurse and the doctor, of course, take an active role in this. They need to tell the patient about pathology, cause, treatment, interventions, alternatives, and recovery. We need to start teaching that from the start. Let them know what to expect and what we expect from them, because they're going to have to work for it. The nurse and the doctor let the patient, let the family know everything just based on what they've got. That's going to change, of course, throughout treatment. And then teaching, of course, continues after and through recovery. Rehabilitation will include stuff like incentive spirometer, deep breathing exercises. And then when the patient's ready to go home, the family needs to know what to look out for, because as mentioned before, this could happen again. After a pneumo, you're more likely to get another pneumo, so they need to know what to look out for and when they need to call 911 or get to the ER. And that's pretty much it. Here's some references that we used. We've got a couple of pages of those. Thank you for your attention. That's pneumothorax.